all of you. And we move immediately because time is running. I will give the speech to one of my mentors, Rudy Campo, that is already connected, who will introduce the STORZ Symposium just with only 2 minutes of delay. So please, Rudy.
Thank you very much, Attilio. So congratulations to everybody. Really, really excellent Congress. This session, short session, but we will ask from the whole audience to contribute to this session because we first have the introduction and the lecture of Attilio. Then we will have a poll with some questions, and then Attilio and myself will discuss. And we will start immediately because Attilio is at his best when he gives a lecture, don't you think? The current possibilities, Attilio, of office cystoscopic surgery from diagnostic to advanced operative procedures. What did you prepare for us?
Yes. Okay, thank you, Rudy. So if you can go on with my video, I prepared just a video in order to be on time, less than 10 minutes. I have time for the polls and the discussion. So Hector, go with my video. I will speak over the video. And I prepare something that I hope that you will enjoy. So in the meanwhile, I want just to thank STORZ for having arranged this symposium. And okay, here we are. Okay, go ahead. So speaking about the current possibilities, in 10 minutes is really challenging. I will try to do a long story very short. First of all, I would love to announce you that probably in the next months, we will have a common definition finally of the in-office and operating room setting, because a group of leading experts from the global community of hysteroscopy, AGL, a European Society of Gynecological Endoscopy, are joining their minds in order to do this ambitious project on hysteroscopy nomenclature. I can anticipate that the setting will be defined according to the level of pain management possible in the facility where you are going to perform your procedures. And we will define in office setting, but this is still to be validated, the setting where you can administer a level of pain ranging from level 1, so no medication, up to level 3A oral medication. So in the last 30 years, we had many technological innovation, mostly for our procedures in office setting, up to the revolution of the digital hysteroscopic clinic, which is a new concept in precision medicine, which combines the methodology of ambulatory operative hysteroscopy with high-end technology that typically is seen only in the operating rooms. In the digital hysteroscopy clinic, you have a perfect integration between advanced video endoscopy and other imaging modalities, mostly 2D and 3D sonography. So better possibility to reach proper diagnosis and best treatment for your lady. Currently, the digital hysteroscopy clinic are 3 in the world. The first one was in Leuven by my mentor, Rudy Campo, Belgium. Then it was followed by our common friends, Giuseppe Bigatti in China, in Shanghai. And then one of my best fellow, Ursula Catena, went to Rome and had the possibility with Professor Scambia to create another hysteroscopy digital clinic. If we think about evolution, miniaturization of the scope has been fundamental. From purely diagnostic 5.46 millimeter scope, we are now able to use hysteroscope of less than 3 millimeter, compact hysteroscope. And in between 5 and 4 millimeter, you have also the possibility to have hysteroscope with an operative channel through which you can insert instruments inside the cavity. But we have also the possibility to have a better distension of the uterine cavity, thanks to more and more sophisticated electronically suction and irrigation pump that you knew during these years. But I think that the best innovation has been to move from operative procedures only with mechanical instruments to procedure even with the use of electrosurgery. So You know that in the past, but still now, many pathology can be treated with mechanical instruments. Minor pathology, small polyp, you can do target type biopsy, you can treat septic uterus. First of all, Alberto has shown the treatment, as Rudy does, and also Jaime Ferro with scissor of dysmorphic uterus. So mechanical instruments are very important, and you really have to know how to use. There are even more sophisticated instruments as the spirotom developed by Rudy Campo that it can be used if you want to do an endomyometrial biopsy in case of suspicious of adenomyosis. You insert this instrument in the outer sheath of the trophy scope. But we know that thanks to the possibility of miniaturized, even bipolar electrodes, you can use this wonderful instrument in your office setting. And you can perform large polypectomy, dividing the polyps in many pieces. You can do small myomectomy. You can do synechiolisis. You can treat even large, broad-based septa, always in office setting, without anesthesia or with mild sedation. We had also an evolution in the electrosurgical generator, and probably you will see in the next slides, which are the most commonly used all over the world. And they change not only in the outer surface of themselves, but even the programs that are possible to be selected on this new generator are fantastic in order to release the proper amount of energy with every specific instrument that you are going to connect. But we have also new instruments that appear in the market in the last years. One is the mini resectoscope. Gianpietro Gobini was the first with the 16 French unipolar, bipolar mini resectoscope. Then a new fantastic, purely natively bipolar mini resectoscope of 15 French was developed by STORZ. And I personally adopted this device in my unit, and I can tell you that some pathology that could be very challenging with miniaturized 5 French electrodes can now be treated in office setting. Polyps, fundal polyps, myoma. You can also use the pointed electrodes to do metroplasty. I personally use even to do the metroplasty for T-shaped uterus. You can remove retained product of conception, but keep attention, in the operating room, we can use the mini resectoscope even to perform the treatment of cesarean scar pregnancy. And keep in mind that this is a pure native bipolar resectoscope. The circuit is closed in between the active and passive electrodes. And you have also the possibility with this miniaturized resectoscope to use cold loops, which means not electrified loops, in order to perform the enucleation of the intramural component of the myoma. And then you can also use this loop for the removal of the fragment from the uterine cavity without running the risk to waste the electrified loop and to bend them. But we know that in last years, we have also the possibility to use in outpatient setting, even small diameter tissue removal device that have changed our way of approaching some intrauterine pathology. The 19 French intrauterine Bugatti system is one of the tissue removal device that, thanks to the small diameter, you can use in outpatient setting. Personally, we use the tissue removal device in office setting to perform large polypectomy, to perform the removal of retained product of conception. And in the last 2 years, we are using to perform the visual DNC of the uterine cavity in case you need a huge amount of endometrial specimen for histological analysis. And both the mini resectoscope and the Bugatti shaver are very versatile. The mini resectoscope can also fit a telescope bridge through which 5 French instruments can be inserted. On the other end, in the channel of the blade of the shaver, you can also insert very robust and very effective 3mm instruments to be used to perform other procedures that probably with the blade you are not able to do. But to conclude, I think that probably the training received the best innovation in the last 10 years. And I think that the program developed by the European Society of Gynecological Endoscopy has largely contributed to standardize what is a proper training in endoscopy, and of course, even in hysteroscopy. And it has been established the importance to do a training first in vitro on your pelvic trainer, but then it's important to find a place where you can do a training in vivo, a little bit more difficult in COVID times, but it's very important that you know in vivo how to use your instrument. But me and Rudy strongly believe that theoretical knowledge are mandatory when you want to approach hysteroscopy technique. This is the reason why we have tried to update the manual modern hysteroscopic approach to genital pathology, that I hope it will be ready for the next Congress, probably in October it will be ready. And in the next Congress, the European Society and the Global Congress, I hope that we can promote this manual that will be distributed for free by KARL STORZ. Thank you very much for your attention.
Well done, Attilio, well done. You impressed me again. Very good lecture. So, and I must say to all the audience, Attilio is the first and probably one of the only one today who accepts students in his office and give them the possibility to train really on wake patients to learn the ambulatory procedure. So congratulations, Attilio, you're really doing a fine job. So now you have to work, people out there, wherever you are in the world. We will start with the poll. Can I have the first question, please? Please answer at your discretion. Do you already perform operative hysteroscopic procedures outside the conventional hospital operation room? Wherever it is, but not in a conventional operative room environment. Please answer. And the second question is, if yes, which kind of analgesia, anesthesia do you use in your setting? In the meantime, Attilio, I will put the question so that they have time to answer. Do you know anything about FDA approval of the mini resectoscope in the United States?
Not yet. I think that they are still working on that, but probably in the next session, our common friend Kate Isaacson can say something about that.
Okay. And what
I heard that probably they received the approval. I don't know, Kate, if you are online, or Tony Carugno, probably you can say something about that. Kate.
Yeah, we had it approved, and then they took it back to get their 510K approval. And so they're in the process of finalizing their 510K submission as of yesterday. So I assume that will come back to the United States within the next, I don't know, 3 to 4 months.
Thank you, Kate. And can we have the answers? Is this possible? Okay. So we have in a specific room in the hospital, 50%, in a specific operating room outside the hospital, 10%, in private office, 19, and no 21. And then we have, if yes, only local, 28, IV mild or conscious sedation, 23, other types of anesthesia, 13. I think Keith and Attilio, very interesting for our discussion on definition.
And probably we are on the right way. So as I anticipate, probably the best way is to join together the terms office outpatient, because most.
Can we have the next poll, please? In the meantime, just to continue, just for time purposes. Yeah. And the second question, please. Okay. Which is the main limiting factor you experience to provide your patients an ambulatory, outpatient, or office hysteroscopic surgery? Cost, compliance, availability of instrumentation, or the learning curve? I tell you, do you experience with the mini resectoscope problems with the ceramic inside portion?
Yeah, it happened just last day, but I think because I use a lot. So probably, I think it's also very important that you don't cut when the loop is already very close to the tip of the hysteroscope. This is a problem that with all the resectoscope, it can happen that you can burn the distal lens, or you can create problems to the ceramic just around the outer sheath. But I think that personally, I noticed a greatest advancement when I changed from the second version to the third version of the Autocon. The device works much, much better.
Okay, and then there is, can we have the results? Is it possible to see? Everybody can see. Okay, availability of instrumentation is the most limiting factor. So you have to talk to STORZ, probably. Yeah. And then, Attilio, people are quite interesting to visit you. Is it correct when I may say them that if they follow the GCH learning program and when they have level 2 certification, then there is a possibility to visit Naples or Leuven or whatever center who offers a clinical teaching?
No, I can tell you that I'm really very proud to say that even in this period of COVID pandemic, we have already scheduled 20 GCH sessions per this year and already full. So already sold out. And we do even for people coming from South America that come to visit my center. So we try also to make them inside the program in order to do the proper training, theoretical knowledge, psychomotor skill, and then to go in the ambulatory and operating room to be your first operator in your surgery. But this is the training that Rudy was the first to standardize, this pathway of learning that is very important, because what happened in the past that people go straight away in the operating room or in the ambulatory setting, but they do not know anything about four-oblique view scope, about hand-eye coordination, about bipolar, monopolar, and this is unacceptable for our patient and for our clinical activity.
Well done, Attilio. So the only thing you have to do now is to invite everybody to the ESG Congress in Rome, and they can visit your center.
We arrange a tour from Naples to Rome straight away and coming back. So
Rome will be 3 October, I think.
Yes, yes. It's the first week of October.
So no COVID anymore. So obviously, everybody, please fly into Rome so we can see each other. I'm desperately seeking to travel again. So I think we can have the last poll, and we can close the session because our time was very limited. But I hope you enjoyed it, and I thank everybody being so active in the poll and to give us your opinions. Attilio, you have the last word.
I mean, I thank you for being the best moderator. So I think that even the questions were very pertinent. So probably STORZ will contact you in the future days in order, because we see that availability of instrumentation, which sometimes is, it means that you don't know perfectly the instrumentation, is one of the main limiting factors. So, but it means that there is work to do, even on the behalf of the company, to contact people that are very interested, very passionate in this technique, because if we have 700 people at this moment connected to see we speaking about hysteroscopy, it means that there is a huge worldwide interest towards this fantastic technique.
Thank you very much.